Hi, and welcome to Radonc Talks, a lecture series created for students and residents of radiation oncology. My name is Ria. I am currently a fourth-year Radonc resident at the University of Pittsburgh, and today I'm excited to get into the role of radiation in stopping bleeding. This will be our last talk in the Radiation Emergency series. Obviously, bleeding can occur from tumors that are located anywhere in the body, not just the disease sites that I have listed here on this slide. But I'm hoping that by going through some of the areas where bleeding is more common, such as lungs, the abdomen and pelvis, and the head and neck regions, we can learn some general principles that can then be applied to other areas. Let's start by talking about the lungs. We're not just going to talk about hemoptysis, but also airway obstruction, as the two can often go hand in hand. Anytime we're dealing with a tumor that is adjacent to or invading a patient's airway, that tumor can cause either compression and obstruction, compromising the patient's breathing, or it can cause bleeding and hemoptysis, which is equally life-threatening. Anytime patients have significant acute airway compromise, we need to realize that radiation is not going to take immediate effect. It takes time for radiation to have an effect. And so there are much faster and more effective palliative options for these patients. For example, bronchoscopy followed by stenting or laser to try and open up the airway or to identify and stabilize the source of the bleed. Radiation is effective, but it takes time. And most patients do not experience palliation right away. So it can take 24 to 48 hours to relieve hemoptysis. It can take up to 1 week to relieve dyspnea. What you'll learn in this talk is that radiation is actually really good at stopping bleeding. So we see in this table, if we're radiating for a patient's hemoptysis, the response rate is quite high, 80 to 90%. Of course, radiation can also help relieve things like chest pain, cough, dyspnea, but it's going to be most effective at stopping the bleeding. There's an older ASTRO guideline from 2011 with some recommendations for providing palliative radiation in patients with non-small cell lung cancer. In this guideline, patients with good performance status are recommended to have a higher dose fractionated palliative radiation regimen, something like 30 gray and 10 fractions equivalent or greater. And the reason is because there are some randomized trials that show a modest overall survival benefit when we use a higher dose of palliative radiation. It's important to note that a higher dose of radiation is also associated with higher esophageal toxicity. But because it's a modest overall survival benefit, if the patient does have good performance status, we should consider something like 30 gray and 10 fractions or higher. On the other hand, in patients with poor performance status, the guideline recommends treating with a shorter fraction palliative course, something like 20 gray and 5 fractions, 17 gray and 2 fractions, where the dose is given 1 week apart, or 10 gray and 1 fraction. These regimens were all noted to provide good symptomatic relief with fewer side effects. And just to show you I'm not making this up, this is the table that was referenced in the 2011 ASTRO guideline, and it just shows several randomized controlled trials that assessed different palliative regimens for patients with non-small cell lung cancer. And the results that are highlighted in the red boxes are those that showed a significant improvement in overall survival with a longer fractionation schedule. The benefit, again, was very modest on the range of maybe 1 to 2 months, but the p-value was significant, and based on this, ASTRO recommended longer and higher dose fractionation schedule in patients with a good performance status. The guideline for palliative radiation in non-small cell lung cancer was then updated in 2018 by ASTRO, and this time a distinction was made in the recommended treatment for stage 3 versus stage 4 non-small cell lung cancer patients. So for stage 3 cancer patients who are not suitable for curative therapy, but are still candidates for chemotherapy, have a decent performance status, and a life expectancy of at least 3 months, ASTRO recommends administering platinum-containing doublet chemotherapy concurrently with a moderately fractionated palliative thoracic radiation regimen. And this is based on the results of 3 randomized controlled trials, 2 of which actually showed an overall survival benefit to chemoradiation versus radiation or chemotherapy alone. So again, we're talking about stage 3 lung cancer patients who technically have a curable disease, but for some reason they're not suitable for curative therapy. Maybe they can't tolerate a full course of radiation. Whatever the situation, if they are candidates for chemo, have a decent performance status, and a life expectancy of at least 3 months, the recommendation is, if possible, to consider doublet platinum-containing chemotherapy given concurrently with radiation. And radiation regimens that you can consider are things like 20 gray in 5 fractions, 30 gray in 10 fractions, and 42 gray in 15 fractions. Now, for stage 4 non-small cell lung cancer, and just to review, stage 4 non-small cell lung cancer is considered stage 4 when there is a separate tumor nodule in a contralateral lobe, when there is a pleural or pericardial nodule or an effusion, and if we have extrathoracic metastases, obviously. So for stage 4 patients, concurrent chemoradiation is not recommended outside of a trial, just because there's no level 1 evidence to support this. So just keep in mind the updated 2018 ASTRO guideline to consider doublet chemotherapy concurrently with radiation for stage 3 patients who are not suitable for cure, and not to consider concurrent chemoradiation for stage 4 patients. So we talked about a lot more than just bleeding, but hopefully by touching on things like non-small cell lung cancer and obstruction, this gives you an idea of how to handle patients with lung tumors that require palliative radiation. Let's move on now and talk about GI and pelvic bleeding. I mentioned that this would be a theme earlier in the talk, but radiation is really good at stopping bleeding. And just to highlight this point, I've included a study that looked at the rates of improvement in bleeding across a few different sites at the end of radiation. And as you can see by the numbers in the table, at the end of radiation, the improvement in bleeding ranged anywhere from 65% to 100% across several different sites. And so the moral of the story is that radiation is very effective at stopping bleeding. Now, in any palliative situation, I think you're not wrong for considering some of the most common palliative radiation regimens. In my mind, these are 8 gray times 1, 20 gray in 5 fractions, or 30 gray in 10 fractions. And we decide based on the patient's performance status if we think they're going to derive a longevity benefit from using that longer fractionation schedule versus something shorter. However, in certain disease sites, you'll hear about unique regimens that can be used for palliation. And one such regimen to be familiar with is what is known as the quad shot regimen for the pelvis. The quad shot regimen is called so because it's just 4 fractions that are given twice in a day, so they're delivered BID 6 hours apart, and so the regimen can be completed in just 2 consecutive days, hence the name quad shot. It came from the RTOG 8502 study, which was a phase 2 trial where patients were palliated for pelvic malignancy. So once again, the regimen is 4 fractions at 3.7 gray per fraction for a total of 14.8 gray in the entire course. The treatment is delivered BID with fractions spaced 6 hours apart, and it's delivered over 2 consecutive days. The major advantage is that patients get done quickly because it's just 2 consecutive days, so it's a quick benefit. And it can also be repeated up to 3 times every 4 weeks for a total of 44.4 gray as needed. In this particular trial, they found that 60% of patients completed just 1 course and only 20% of patients completed all 3 courses. Given that this was a palliative treatment, there was a pretty good complete or partial remission rate, and the toxicity rates were very low, with only 1 acute GI and 1 late GI occurring in patients that received 3 courses of the radiation schedule. So again, quad shot, 14.8 gray divided into 4 fractions, delivered BID for a total of 2 consecutive days. Just something to be familiar with. And again, just to reiterate, you're not wrong for considering other radiation regimens besides quad shot. This particular study is a retrospective study in patients with gastric cancer that was managed with palliative radiation alone. And patients received an average of 30 gray and 10 fractions, but the range was anywhere from 8 gray and 1 to 40 gray and 16 fractions. And the responses, again, it checks out that bleeding is the most, radiation is the most effective at stopping bleeding. The response rate was 54% in patients that had bleeding. It was 25% in patients with obstruction and 25% in patients with pain, and only one grade 3 toxicity was noted. So it's always tricky when you're dealing with GI malignancy or something in the pelvis to decide what is the best course of action. Again, radiation is very good at stopping bleeding. It's probably less effective at treating something like obstruction, but these patients always have to be evaluated on a case-by-case basis, and you have to kind of discuss with the team the realistic goals from your palliative radiation. The last stop on our journey through bleeding tumors in the body is the head and neck region, and we really only have one slide about that. So not only is there a quad shot regimen for the pelvis, there is also a quad shot regimen for the head and neck region, and I think this study was inspired by the regimen used in the pelvis. So this was a single-arm phase 2 study of head and neck patients with squamous cell histology. Most commonly, they were presenting with dysphagia and pain, but again, these patients can have bleeding as well. And the dose is a little bit lower because we're now limited more by the spinal cord, but the dose is 14 gray in 4 fractions, but just like in the pelvis, it's delivered BID 6 hours apart over 2 consecutive days. And just like the quad shot regimen in the pelvis, this one can also be repeated up to 3 times every 4 weeks for a total of 42 gray. So again, all the same advantages of the quad shot regimen in the pelvis. We get done in just 2 days. It's quite effective. Over 53% of patients had at least a partial response, and 77% had reduction or stabilization of their disease after treatment. And it was well tolerated, with 0 patients experiencing grade 3 or higher toxicity. Now, I always had a hard time remembering the doses because they're so similar but still different for the head and neck region versus the pelvis. And now I have a way to remember it, so I'll tell you as well so you never forget it. For the head and neck region, the quad shot regimen is 14 gray in 4 fractions. Because the pelvis is wider than the head and neck, the dose for the pelvis is also a little bit higher, so it's 14.8 gray in 4 fractions. That's one way to remember it, an easy way like me. If you want to think about it more logically, though, in the head and neck region, you're also limited by the spinal cord toxicity, and so that's why the dose is actually a little bit lower in the head and neck, so that you're not torching the cord. So that pretty much sums up our discussion on bleeding. Now, if you have stuck with the Radiation Emergency series thus far, then I encourage you to stick around for just 2 more slides where I would kind of like to recap everything we've talked about when it comes to handling radiation emergencies and share kind of what I think is the bottom line. These are my top 3 pieces of advice when you are paged about a radiation emergency. So number 1, tumor is the rumor, but tissue is the issue. You always want to confirm that the patient has cancer on pathology. If you do not have pathologic confirmation of cancer, be very hesitant to proceed. The reason is because pathology strongly affects our cancer management, and the last thing that we want to do is burn a bridge to a curative treatment by preemptively jumping in with some type of therapy that we think will help the patient. So always make sure that the patient has cancer, and you've confirmed what type of cancer. The other thing we also don't want to do is treat someone with something like radiation and then realize that their cord compression was actually from an infectious etiology. And in that case, you're really only doing harm by radiation. So you always want to confirm that the patient has cancer and that you're paying attention to the pathology. There will be situations where patients present with an emergency and they get a biopsy and you're kind of waiting on the pathology. It's always a case-by-case decision, but no matter what, make sure that you're clearly documenting what's going on. So is the pathology pending? Are you operating based on preliminary path findings? Are you awaiting final path? Whatever it is, make sure you're clearly communicating with the patient and clearly documenting what's going on. So pathology is very, very important. The second thing I'll say is that you should be very hard-pressed to offer emergent radiation in the setting of prior radiation to the same area. So when you're evaluating the patient, always check both in the chart and by verbally asking the patient and or their family if they've ever had prior radiation, especially in overlapping sites of concern. And if we are dealing with a situation of re-irradiation, you want to make sure to create a plan sum with dosimetry and document the doses to your organs at risk, especially things like the spinal cord that we certainly don't want to burn. So, in the emergent setting, practice patterns will vary based on institution, but if over the weekend you're expected to kind of treat blindly without making any contours, without calculating things, if it's a setting of re-irradiation, I would be very, very hesitant to go ahead and initiate emergent radiation. And then finally, this piece of advice transcends all medical fields, I think, but you always need to evaluate the patient at the bedside. There have been multiple times where I've been on call and paged with what seemed like very urgent or emergent findings, and then I went to evaluate the patient and things were actually very stable, and I felt that we had some time to create a decent plan for the patient and proceed with our radiation in due time. So always evaluate the patient at bedside. Make sure that you're trusting but verifying all the info that you're getting from other team members. So my 3 key takeaways are pathology, pay attention to prior radiation, and always evaluate the patient at bedside. On this very last slide, I just wanted to kind of recap all the common palliative radiation regimens that we have discussed. I think we've talked about these quite extensively. Some of the unique ones that I'll highlight are 10 gray and 1 fraction for lung, as well as 17 gray and 2 fractions spaced 1 week apart for lung. These are regimens that you would only consider if the patient has very, very poor performance status, and you're concerned about them living, possibly even over a period of just a couple of weeks. And then, of course, in the abdomen, we talked pretty extensively about the quad shot regimen in this past discussion. One other thing that I'll mention is just a clever little thing that I've seen done by one of the attendings at my institution. We had a patient with a metastatic spinal cord compression who needed to be treated on a Friday, and we wanted to treat with 20 gray and 5 fractions total, but my attending actually led with 8 gray and 1 fraction on a Friday, gave the patient a break over the weekend, and then we finished out the course with 3 gray times 4 fractions. So it still adds up to 20 gray total, but we just kind of led with a slightly higher dose of radiation, which I thought was clever and worth mentioning. And that is all I have. If you have listened to all the videos in the Radiation Emergency series, thank you so much for sticking through it. When I was a PGY2 taking call for the first time, I was very, very nervous, especially when I got paged about emergent consults. So I just want to share some advice that one of my past chief residents shared with me, and that is that if a patient is going to die within the next couple of days or so, then there is no chance that radiation will have made a difference. And I think that advice is absolutely right. Radiation takes time to have an effect. And if a patient is truly on the cusp of death, then radiation is not going to make a huge difference. And I think knowing that has just helped me kind of breathe easier when I'm dealing with these consults. In any situation when you have a consult, we are blessed in the field of radiation to have a lot of time. There's always time to logically think through things, to systematically go through the patient's chart, get a full history and physical, and then wisely make a decision about how to proceed. So just keep that in mind, and I think that you'll be totally fine. So good luck with everything, and thank you again so much for watching this video.